We have recently purchased a Lumenis AcuPulse laser system with a Fiberlase flexible componentry, and I have used this a few times in the office. My opinion so far is that I really enjoy using this laser. I find it to be very well powered. I have used it in relatively low powers compared to what the machine will allow me to do. I found it to be very effective at treating laryngeal lesions and pathologies at relatively low powers, which gives me great hope that I will be able to use it in more and more lesions and not ever worry about how much power or having inadequate power to treat certain pathologies. I like the ability to trim and break the fiber. I find that to be very effective and useful in management of char that you may or may not get on the tip of the fiber. So far, I have not found char to be a particular problem. The addition of a sheath system to protect the scope, I believe, is quite important, as the fiber system is sharp and I believe, can tear or cut the internal sheath system within the flexible laryngoscopes. I think that the use of a sheath system is particularly helpful, and I think will limit any concerns I have regarding the safety of our scopes, as well as sterile processing and cross-contamination of the scopes. The flexible laser system allows me to treat lesions in an office-based setting through a flexible laryngoscope. I think for certain pathologies this is particularly valuable. I think that there are a number of situations in which I choose or would prefer not to take a patient to the operating room with general anesthetic, and would prefer to do the procedure under local anesthesia only or topical anesthesia only. In those settings, often for small lesions, I think the fiber-based system works particularly well at preventing patients from unnecessary or excessive operative interventions. Other patients who have extensive papilloma lesions and almost never have a significant disease-free period will often enjoy not going back to the operating room to have their papillomas addressed, and can treat them in the office in a relatively brief procedure. A number of our patients tend to be elderly, often have had adverse events with general anesthesia. In those situations, I will choose to use a fiber system if it's at all possible to treat the pathology. And the last group are the group of patients in whom they are particularly challenging to expose, where getting adequate laryngeal exposure to perform the procedure is either extremely challenging or not possible. And this is a small subset of patients, but these patients in particular, the fiber-based flexible systems allow me to treat pathology that I otherwise couldn't access.
Regarding the use of the hollow fiber of the CO2 waveguide, the CO2 hollow fiber, I had the chance to work with it. I have the chance to work with it since more than 6 months and more last year, and it's a big breakthrough because it's not opposite to the conventional laser. It's complementary. So I'm sure that this tool will be on use for office-based procedures. It will be combined and make the CO2 laser surgery available in the office. You will be able to use it transnasally with your video endoscope. And also it will give access to difficult area when you cannot use the conventional CO2 laser. And above that, it is probably a next step. Probably this fiber will be combined with the so-called robotic surgery, because it will be possible, I did it already, to pass the fiber through a laser arm and to combine the magnification provided by the robot and the CO2 fiber. So it's a great development. And this fiber is very strong, reliable. You can deliver 40 watts, no problem. The cooling is easy, it's normal air, no need for special gas like helium. You can reshape the fiber during the work if you need. It's very practical. What I prefer with this fiber is, as I told you before, is that I can have access to part of the airway that I can approach, but in a much more difficult way with the straight beam. For instance, if you have to go into the trachea, with a straight beam you need to connect your arm to a bronchoscope, rigid, big. It's not that practical. With the fiber, you can use it with a small telescope, and it's flexible. You can go a little bit to the right, a little bit to the left. It's much more practical. And also, it's not my part of the job, but you can enter into the nose, probably into the sinuses. So there are many parts of the airway where the fiber will make a difference. Besides, as I told you before, the office-based procedures.
I've used the Lumenis Fiberlase system, both in the larynx and in the trachea. The advantage is when you don't have line of sight, it allows you to manipulate the laser beam so that you can bend it around angles. This can facilitate delivery of laser energy in relatively large fields. When I'm working in the hypopharynx, the field is much larger, and oftentimes you find yourself having to reposition the microscope multiple times, particularly if you're operating at 7 to 10 times life magnification, so that you have your microscope coned in on a relatively small area of the hypopharynx. Oftentimes, if you have a lesion in the hypopharynx, once you've identified it and identified its borders, you can reduce your magnification to 2 or 3 times life magnification. In this instance, when you're under relatively low magnification, you find yourself repositioning the microscope multiple times, and this can be difficult each time to realign the micromanipulator. In those particular instances, the Fiberlase is much quicker because you can accept the larger operative field with relatively minimal need to have to reposition your microscope and articulated arm delivery system.
I think we're just beginning to understand how the flexible fiber lasers can complement our practice and the treatment of laryngeopathology. I find that the more experience I have with them, the more procedures I'm willing to undertake and find them useful. As I use the flexible CO2 delivery systems, I have extended my indications to lesions that I otherwise would have treated in the operating room. For example, pharyngeal stenosis after laryngectomy, where the pharyngeal stenosis can be seen at the base of tongue. I found that fiber-based technologies have allowed me to perform radial incisions and expand the patient's swallowing passages much better than I would have done previously in any office-based technique, and has kept patients out of the operating room. Other techniques in treating saccular cysts I have performed recently, and hope that these will prove promising techniques in the future and can avoid general anesthesia and operative techniques for the treatment of these lesions in the future.